Hi everyone. So today we're going to be doing this question. It reads, a 35-year-old woman presents with several weeks of polyuria. She has no significant past medical history. Her family history reveals multiple kidney stones. Okay. Complete metabolic panel reveals the following values. If you look at the values, you notice that the calcium is high. Everything else is normal. Additional tests show that PTH is above normal and urinary calcium excretion is above normal. Okay, so according to the boxes method, our first box should include the clinical features. Three most important clinical features. Three. So let's choose what our um, most important clinical features are. I'm just going to highlight them in yellow. So when I'm thinking about clinical features, the first type of thing that I like to choose is lab values or x-rays. Lab values or x-rays or imagery, just because those give the most solid information, right? So for here, of course, the high calcium is always a clinical feature. High calcium is always telling you something about a patient. It's almost always when you see high calcium in a question, the patient is going to have something to do with that. It almost determines the fate of the question. Um, and we see elevated uh, PTU, PTH, and I guess elevated um, urinary calcium excretion. The other signs that we have is that it's a familial issue because the mom also had multiple kidney stones. They're presumably also calcium kidney stones and polyuria. So in this question, we have more than three. We have almost five. But if I were to choose only three, I would probably go with the signs, more the values that we got from the patient. Okay, so let's draw our first box. Let's draw them here.
So, for
So
the clinical features, we'd focus on one, high serum calcium level, hypercalcemia.
ChatGTP. Okay, never mind. So let's continue. So yeah, for these we will focus on our clinical features. So clinical features box is going to include the following. So one, calcium is high. Two, thyroid hormone is high. It's already sounding like primary hypercalcemia. And three is urinary calcium excretion is high, is increased. Okay. And so if you remember, the first box is clinical features. The second jump that we have to make from the first one is our differential diagnosis. So, and it sounds like the question is asking us for a diagnosis, so the box sequence ends here, so we don't need to know more about it. We don't need to figure out the the diagnostic method box or the treatment box. We don't need to figure these out. Now, for differential diagnosis, as I said, once you correctly identify your clinical features, it's easy to come up with differential diagnosis. And it's important to rank them correctly because which clinical features you figure out to be the most important are the ones that are going to feed into your differential diagnosis. And those are the same ones that you're going to be picking for your answer. So if you have high calcium, high parathyroid hormone, that is primary hypercalcemia. And I believe that is the answer to, or primary hyperparathyroidism. Primary hyperparathyroidism. And I believe that is the answer to this question, but it's a little too soon to jump to a conclusion. Okay. What would be your number one? Number two? I guess for number two, since this is a familial thing, one can think about familiar hypocalciuric hypercalcemia. However, we do have high calcium, so that's not really a good choice here. But let's just put it down. Familial I'm just going to write the hypocalcemic hypercalcemia, so FFH, right? Now, once you have about 3 of these, the box sequence ends. So you can proceed to the choices. And we'll talk about the choices. I think the choices teach us a lot in this question. So how would primary hyperparathyroidism look? Primary hyperparathyroidism is the most common cause of hypercalcemia in kind of a young healthy patient. If you have an old type of like super sick patient, the most common cause of hypercalcemia is likely a malignancy, right? With secondary hyperparathyroidism, remember that this is as a result of a kidney problem, that your kidneys aren't able to get rid of your phosphate. The phosphate ions are binding with calcium ions. That is causing your parathyroid hormone to produce more parathyroid hormone. And your calcium levels are still high. If your parathyroid hormones are ever able to overcome the uh, the thyroid hormone, or if the parathyroid hormones are ever able to overcome the calcium, then you'll get tertiary hyperparathyroidism. So in tertiary hyperparathyroidism, the difference with secondary is that your calcium level is actually high. Milk alkali syndrome is in someone who has a lot of consumption of lots of calcium. So in that case, you will see a parathyroid hormone that is decreased. Excessive vitamin D intake. So in excessive vitamin D intake, you will get a lot of calcium absorbed. Okay. The only thing is, I'm not sure if your urinary calcium excretion will be high, is because your vitamin D puts your body in a mode that's, I want to keep all the calcium I have. So I think it would give you a low urinary calcium excretion. Familial hypocalciuric hypercalcemia, as we said, it's a state where, first of all, it's a clinically insignificant thing, meaning it's just a finding. It doesn't mean it's not a disease really. It doesn't cause a pathology. It's very hereditary. And just pay attention to the name. It's hypocalciuric. So these patients will have low calcium urine. The way you see this in a question is that you'll literally see the calcium is low in the question. But everything is typically okay with them. They may or may not have a hypercalcemia. The problem with these patients is that the receptor on the parathyroid cells is basically having a little bit of resistance to calcium. So you can think of it as a dials for where calcium levels are supposed to be. For these people are set a little bit higher than a normal person due to mutations on that receptor. So their calcium levels are a little higher than normal. They're releasing a little bit more parathyroid hormone than normal. So that's why they have a little bit of a lower calcium in their urine. With sarcoidosis, those sarcoid granules, they're producing active form of vitamin D that is leading to a hypercalcemia. Okay, so interestingly, lymphomas can also lead to hypercalcemia via the same pathway. Multiple endocrine neoplasia is an interesting answer because I think this question can also apply to can also in fact be multiple endocrine neoplasias, and I'll tell you why. So since the mom also had a pituitary, a primary hyperpituitarism, this could likely be a familial pituitary adenoma situation, which is seen in men 1, I believe, and men 2A. So that could also be the answer, but it's a possibility. I'm more confident that it's A, that A is more correct. And you will come across situations like this on the exams because sometimes you feel like two things are both correct, but one is certainly more correct, and you should comfortable with going on with the one that you feel like is more correct in situations like this. Hypervitaminosis A doesn't really affect calcium, and hyperthyroidism doesn't really affect calcium. Now, so our answer for this one is A. So it was a fairly straightforward question. It had a lot of choices. I guess it was important to go through the choices and make sure nothing else makes sense. And our first differential diagnosis is indeed the best differential diagnosis. But once you find the correct clinical features, it's easy to get you from your clinical features box to a differential diagnosis box. Now, if you like this whole boxes analogy and if you like the way I explain things, please feel free to check out my website in the description. Thank you for watching this video.